All right, great. So welcome everyone. My name is Megan, and I'm with the Pulmonary Hypertension Association. We are really grateful for everyone coming out to listen to this webinar today. So today is November 10th, and I'm very pleased to present today's webinar, Improving Patient Outcomes and Early Diagnosis and Examination of the REVEAL Registry. I'll be moderating today's events, and I just want to briefly mention that today's event is unique for PHA because we have actually invited all members of the PH community to join in on this webinar. So just as a note, we will have medical professionals, patients, caregivers, and all other people interested in this topic on the line. So please keep in mind that we do have a very diverse community participating in this call, so when you ask your questions at the end, please make them general, not case-specific, and appropriate for everyone participating. Today's program will include a presentation by Dr. McLaughlin, Dr. Brown, Dr. Chanik, and Dr. Badish, and the presentation will be facilitated by Dr. Elliott. And afterwards, we'll have a brief question and answer period. So if you can please hold your questions to the end, that would be great. And if you have questions that come up during the call, you can submit them via the chat function. So without further ado, I want to welcome Dr. Elliott, who will give a brief introduction. He comes from the Intermountain Health Center in Utah. And we're very excited to have him facilitating this webinar. So Dr. Elliott, you can go ahead and unmute your line by pressing *7. Thank you.
Megan, thank you very much. It really is, I think, my pleasure to welcome the audience on behalf of today's webcast faculty. And I would like to just give the audience an overview of today's presentation. We will first hear from Dr. David Badish, who will give us a summary of what patients diagnosed with pulmonary arterial hypertension in the contemporary era look like. Dr. Lynn Brown will talk about now the known associations with delays in diagnosis. And Dr. Richard Chanik will talk about characteristics of patients who are diagnosed earlier in their disease. And finally, Dr. Val McLaughlin will discuss how early diagnosis can help patients with pulmonary arterial hypertension. For those who may not know, I'm a professor of medicine at the University of Utah School of Medicine and the director of the Pulmonary Hypertension Center at Intermountain Medical Center in Salt Lake City, Utah. And I thought we would start today's webinar by describing what I think is arguably the poster child for earlier diagnosis. Anne Marie Garrity, a nurse, took her sister Kathleen to doctors for 2 years, saying to the doctors, "It's really too severe, these symptoms of breathlessness that my sister has, to be asthma." And finally, after 2 years, her sister was diagnosed with pulmonary arterial hypertension at a time when she was 6 months pregnant. And she died shortly after giving birth to her son, whom you see in this photograph. Earlier diagnosis, I think, in her case, might have led to a different outcome. And I think that's why this subject is so important to us. One of the take-home messages, I think, for today's webinar is that delays in diagnosis of pulmonary arterial hypertension are all too common, and they're often quite prolonged. This is data from the REVEAL Pulmonary Arterial Hypertension Registry reported out in 2006 and 2007, reports of over 2,000 patients. And what you can see on the slide is that the median time to diagnosis, that is the time where half of these patients had been diagnosed, was more than a year. It was 14 months. And fully, almost 3/4 of the patients had very advanced disease at the time of their diagnosis, either fulfilling criteria for functional class 3 or functional class 4. Perhaps even more alarming, 1 in 5 patients had more than 2 years elapsed from the time of their first pulmonary arterial hypertension symptom, typically breathlessness, until the diagnosis was made. And in an era where there is effective treatment, it just cannot be acceptable any longer to have these long delays in diagnosis of a progressive and often fatal disorder. At this point, I would like to introduce my colleague and friend, Dr. David Badish, who's a professor of medicine at the University of Colorado Medical Center and director of the Pulmonary Hypertension Center at the University of Colorado, to talk with us about characteristics of pulmonary arterial hypertension now as we've come to learn them through the REVEAL Registry. Dr. Badish.
Thanks, Greg. It's a pleasure to be a part of the webinar. I'm going to briefly take you through some of the findings from the REVEAL Registry. These are my disclosures of commercial interest, and I should note that the REVEAL Registry was sponsored by Actelion. The registry, however, has been conducted with very considerable independence by the investigators. So what is REVEAL, and what patients were, I'm sorry, I advanced too far. What is REVEAL? It's a multicenter, observational, U.S.-based longitudinal registry study. All consecutive pulmonary arterial hypertension patients meeting the inclusion criteria were enrolled. Data collection has occurred retrospectively and prospectively over a 5-year course for each of the patients enrolled. Enrollment means, or it occurred at the time of the first visit to an enrolling institution during the enrollment phase. And diagnosis was the time of the diagnostic right heart catheterization at or before the date of enrollment. So what patients were eligible to be enrolled in the REVEAL Registry? They were patients with pulmonary arterial hypertension, generally meeting the definition of WHO Group 1 PAH, with documentation of a mean pulmonary artery pressure of greater than 25 millimeters of mercury at rest or greater than 30 millimeters of mercury with exercise. They had to have had a pulmonary capillary wedge pressure of less than or equal to 18 millimeters of mercury at rest, or a left ventricular end diastolic pressure less than or equal to 18 millimeters of mercury. And I should mention briefly that the typical definition for WHO Group 1 pulmonary arterial hypertension is a pulmonary capillary wedge pressure less than or equal to 15 millimeters of mercury. So the REVEAL Registry did expand that population just a bit and included patients with a wedge pressure between 15 and 18 millimeters of mercury. We have been careful, however, in the analyses to denote whether or not we've included those patients with a slightly higher wedge pressure. So patients had to have had a pulmonary vascular resistance of greater than or equal to 240, and they had to be 3 months or older at the time of diagnosis. So the registry involved consecutive enrollment of both newly and previously diagnosed patients for a total of 3,518 consented patients. Enrollment of the first 2,977 patients was completed on September 11th, 2007, and an additional cohort of 500 plus newly diagnosed patients was subsequently enrolled. The registry involved a broad geographic distribution of sites. You can see from California on the west coast to the east coast. While some of the sites were larger centers, there were also some smaller sites participating in the study as well. I believe there were eventually a total of about 55 sites participating in the capturing of data for the REVEAL Registry. This slide shows the distribution of patients and how entry criteria were met. This slide pertains particularly to the first 2,977 patients enrolled in the registry. Of those 2,977 patients, 2,965 had a mean pulmonary artery pressure of greater than 25 millimeters of mercury at rest, and 12 patients had a mean pulmonary artery pressure of greater than 30 millimeters of mercury during exercise. So a very small number of the patients met the exercise-only criteria. If you go back over to the left side of the slide, you can see that 2,958 patients had a pulmonary vascular resistance of greater than or equal to 240, and 6 patients were allowed into the registry because of alternative evidence of pulmonary arterial hypertension. 1 met criteria during exercise. And then continuing down the left portion of the slide, 2,620 patients had a pressure at rest of less than 15 millimeters of mercury. That's a wedge pressure of less than or equal to 15 millimeters of mercury. And 95 met this portion of the definition by having a left ventricular end diastolic pressure measured at less than or equal to 15 millimeters of mercury. And then finally, in the left lower corner of the slide, total lung capacity, you can see that 1,417 of the patients had a TLC, or total lung capacity, of greater than or equal to 70% of predicted, while 229 had a total lung capacity less than 70% of predicted. One more mention here of the distribution of patients is that 230 of the patients fell in that group of patients that I mentioned earlier with a wedge pressure between 15 and 18 millimeters of mercury. In other words, meeting the sort of non-traditional definition here, allowing patients in with a slightly higher wedge pressure. Again, 230 patients met that criteria. Moving on to the next slide here, you can see the timeline of the REVEAL Registry. The first patient was enrolled in the latter part of 2006, and the publication process began in about 2008 or so. The first cohort completion of enrollment occurred at late 2007. First manuscript, the design manuscript, was published by Mike Magoon and others in 2008. Baseline manuscript followed about 1 year later or so. The last patient was enrolled in the new cohort in late 2009, and there have been quite a number of manuscripts now published and submitted for publication since then. This is a dated slide. It's, I believe, more like 8 manuscripts or so published to date, and a number of others submitted. The slide also notes last patient, last visit anticipated around 2014 for this first part of the registry. And then, so what are the characteristics of the WHO Group 1 PAH patients at the various U.S. PAH centers? Well, I should first note that the baseline report that was published in CHEST focused on adult patients with traditional hemodynamics, in other words, a wedge pressure of less than or equal to 15 millimeters of mercury. There were 2,525 patients that fell into that group. And the data were presented at the most recent time of enrollment, unless noted otherwise. The target population for generalizability is adult patients seen at U.S. PAH centers, and it includes both newly and previously diagnosed patients. This slide shows the distribution of patients by subgroup at the time of enrollment, and you can see that roughly half of the patients had idiopathic pulmonary arterial hypertension. That's the white portion of the diagram shown on the left side, and roughly half had associated pulmonary hypertension. The circle on the right breaks out that half of patients with associated pulmonary hypertension and shows you that the largest group, subgroup, were patients with connective tissue disease associated pulmonary hypertension, with other groups, congenital heart disease making up about 20% of those with associated PAH, portopulmonary hypertension about 11%, and then smaller numbers for the other diagnostic subgroups. The next slide, shows right heart catheterization parameters at the time of diagnosis for patients in the various subgroups. And you can see that on the left panel is the mean right atrial pressure. Mean right atrial pressure tended to be just a bit higher among patients with idiopathic disease, as well as patients with disease induced by drug and toxin exposure. Patients with congenital heart disease, shown in the light green bar, tended to have a lower right atrial pressure, and that fits with what we've previously perceived as a better right heart compensation in general in patients that have congenital heart disease-associated pulmonary hypertension. The right panel shows the FIC, or thermal elution cardiac index, and not surprisingly, patients with congenital heart disease-associated PAH and portopulmonary hypertension had a slightly higher cardiac index, and those with idiopathic disease, a lower cardiac index. I'm going to let Lynn Brown continue on now. I believe that Greg will introduce her formally, but she's going to show you some additional characteristics of patients from the REVEAL Registry and support the importance, I think, of earlier diagnosis. So thanks very much for the opportunity to be a part of the webinar.
Dave, thanks very much for giving us the background of the REVEAL Registry and importantly showing us how severely impaired most PAH patients are at the time of diagnosis. One of the pivotal studies to come out of the REVEAL Registry has been a study that examined what exactly is associated with delays in diagnosis. And it is my pleasure to introduce my colleague, Dr. Lynn Brown, who's an assistant professor of medicine at the University of Utah and the associate director of the Pulmonary Hypertension Center at Intermountain Medical Center, to review with us the findings from that study. Lynn?
Thanks, Dr. Elliott. I wanted to talk about research that was looked at from the REVEAL Registry and trying to bridge the gap between when patients first start developing symptoms of pulmonary arterial hypertension and when they get to the point of getting therapies that would be helpful. And the REVEAL Registry was used to look at factors that are associated with delay in diagnosis. At the time the study was initiated, there were almost 3,000 patients enrolled in the REVEAL Registry. They excluded patients that were children at the time of diagnosis. And as Dr. Badish mentioned, some of the studies were performed with patients who had pulmonary capillary wedge pressures up to 18 millimeters of mercury. This study, however, looked at patients who had the traditional right heart catheterization hemodynamics with a pulmonary capillary wedge pressure greater than 15. The patients who did not have a beta PH symptom onset were also excluded. Those were approximately 32 patients, which left us with about 2,500 in the total study population. We then divided the group of patients into those that had less than or equal to 2 years between the onset of symptoms and recognition of the disease, and those who had greater than 2 years to disease recognition. And we used 3 indicators of disease recognition. One was a physician telling a patient that they had pulmonary arterial hypertension. The second was the initiation of a pulmonary arterial hypertension-specific medication. And the third was the performance of a diagnostic right heart catheterization. And what this study showed, as you can see, is that 526 of the patients in the population, 1 in 5 had greater than 2 years between symptom onset and disease recognition. Looking at the symptoms of patients, when they first came to attention and what they described, the most important note of the study was not unexpected. It's something we've heard from the beginning from patients, is that the major symptom is dyspnea on exertion. And I think that this slide certainly shows that over 80% of patients in both groups complained of dyspnea on exertion. As everyone knows, this is a very, very generic symptom, and I think that this leads to part of why it is so difficult to catch these patients early, is because they have a symptom that could be associated with multiple disease states. In this chart, the dark blue represents those patients who had greater than 2 years to disease recognition, and the lighter blue are those that had less than 2 years to disease recognition. The only statistically significant finding was that those with edema or more visual symptom of pulmonary hypertension were more likely to have less than 2 years to disease recognition. When we started looking at factors that were associated with a delay in disease recognition, we wanted to look at multiple different factors, including gender, race, geographic area of where the patients were enrolled, and what's not shown on here is also the physician specialty that the patients first presented to. And as you can see here, again, with the dark blue being those patients with greater than 2 years to disease recognition, there were no differences in regards to gender, which is quite encouraging just because it's such a female predominance in the disease that male patients were not seeing a greater percentage of patients with a delayed diagnosis. Along the same lines, there was no difference among race or geographic region. And I should also mention that it didn't matter whether patients presented to internists, pulmonologists, cardiologists, or rheumatologists. All of them had the same number of patients with a delayed disease recognition. Another one of the findings that was identified is that there was no difference in the PH subgroups of patients with and without a delay in disease recognition. The pie graph on the right shows the distribution of pulmonary arterial hypertension subgroups in patients without a delay in recognition. These include patients with idiopathic pulmonary arterial hypertension and familial pulmonary hypertension, but also the associated pulmonary arterial hypertensions, the congenital vascular diseases, the congenital heart disease, portopulmonary disease, and drug and toxin. There was no difference between these groups and the patients that had a delay in disease recognition. They were very similar. The one exception is that of HIV, and we did find that there was a higher percentage of patients who did not have a delay in disease recognition. However, it should be kept in mind that this was a very small number of patients with approximately 42 enrolled. Factors that were associated with the delay in disease recognition in greater than 2 years were identified in the study as well. The largest finding was that patients who are less than 36 years of age were most likely to have a delay in disease diagnosis. This is an observational study, but it's easy to try to think about why this might be. A younger patient may not be able to present to a physician and get an echocardiogram to evaluate their symptoms because of less concern for cardiac abnormalities in a younger patient, where a more elderly patient might get an echocardiogram to assess for coronary artery disease. But again, it's an observational study and difficult to make correlations with the data. There were comorbid conditions that were associated with delay in disease recognition, a history of obstructive airways, as well as a history of sleep apnea. These patients were found to be statistically significant, different from those who had disease recognition less than 2 years. It's unclear from the study whether or not these were patients that truly had these underlying diseases that were masking their disease, or whether they were, in fact, as Dr. Elliott presented his case, a misdiagnosis of asthma that was indeed pulmonary hypertension. And finally, we looked at the hemodynamics of patients with delayed recognition of pH, and not surprisingly, those patients that had less severe hemodynamics, such as having a right atrial pressure less than 10 millimeters of mercury, or having a pulmonary vascular resistance also less than 10 millimeters of mercury, these patients were more likely to have a delayed disease recognition. So the take-home messages from the study are to consider pH, especially in those patients who are younger, those who are diagnosed with an underlying respiratory disease, and also in patients who are unresponsive to treatment of an alternative diagnosis. We all know that asthma is much more common than pulmonary arterial hypertension, but it may be that when you treat the asthma and it's not getting better, that it's time to think about a different and perhaps more rare disease. And that's the end of my talk. Dr. Rich Chanik from MGH will talk next, and I'll let Dr. Elliott formally introduce him.
Thanks very much, Lynn. It's a pleasure to welcome Dr. Richard Chanik, who's a professor of medicine at Harvard University and director of the Pulmonary Hypertension Center at the Massachusetts General Hospital in Boston, to talk with us about characteristics of pulmonary arterial hypertension patients who are diagnosed earlier in their disease.
Thanks, Greg. Pleasure to be here with everybody. And what I'd like to do in just a few minutes, and to really help us understand what is early disease. I think we use the term early disease sort of casually, and we talk about diagnosing patients earlier in the course of disease, which certainly makes sense intuitively. But I think there's a message that may get lost in this whole idea about what is early disease. So we talk about this slide quite a bit, that there certainly is a natural history of pulmonary hypertension that we think advances from preclinical all the way to severe right heart failure with loss of cardiac output. And certainly there is a stage at which patients are less severely functionally impaired, but still certainly have pathologic disease and in fact probably have quite advanced disease. And that's sort of part of the dilemma. And if we go to the next slide, we can see that, in fact, older data supports that concept that the earlier class, if you will, in terms of functional limitation, the better the survival. Although what I like to always point out is that if one looks at these data, in absolute terms, patients in the early registry had quite poor survival even in early functional class. So we have patients who are either had no limitations or minimal limitations who had median survivals of 4.9 years. And considering the demographics that you just heard about in this patient population in terms of age, that I would submit is a very dismal survival, average survival, even in patients who have, quote, early disease. If we go to the next slide, we also see additional data more recently obtained from the early study, which was a clinical trial in patients who had functional class 2 status. And these patients really were an attempt to study patients with, quote, earlier or maybe more mild disease. And in fact, one can see the baseline characteristics compared to prior studies where 6-minute walk distance was clearly further at baseline in these patients who were all functional class 2. So there did appear to be a correlation between better 6-minute walk distance and better functionality, maybe not surprising. But if we look at the next slide, you can of course see that these patients did not have mild disease. So early does not equal mild. And if one looks at the hemodynamics at baseline in these class 2 patients, we all can recognize a patient with, quote, severe pulmonary hypertension with pulmonary vascular resistance in the 800 dyne range and very marked elevation in pulmonary artery pressure and borderline cardiac index. So I think we have a disconnect between what we call early disease functionally and hemodynamically mild disease. And certainly the data from REVEAL, which I won't go into, you're hearing about, supports that notion that it's not just mild. Next. So another bit of data that also supports this concept that recognizing patients early is important, not just because it's good to recognize patients at a milder stage, but without intervention, there's a reasonable likelihood that these, quote, mild patients will progress. And this is actually was somewhat surprising data. This was the placebo arm in that early trial, showing that 14% of patients at 6 months experienced some worsening event, which could consist of hospitalization, clinical worsening, need for more invasive therapy. So that's a fairly strikingly high number, that over 6 months, patients who are considered to be mild or early have significant likelihood of clinical worsening. And I think that really underscores the importance not just of picking up patients early in disease, but actually potentially intervening. Next. So if we were to kind of provide a hypothetical construct for early diagnosis, and again, I do say this is hypothetical because we don't have clear proof that intervening early makes a difference long term. We certainly believe it is. One can look at this very simple slide that shows that dotted line of no functional impairment, where patients presumably have full function, and then the solid line showing the decline in functional capacity with untreated pulmonary hypertension. And if we look at the next slide, we can talk about if we wait too late to diagnose and treat, we certainly may get improvement with whatever therapies we're using in a yellow line, or we may get continued deterioration. But even if we get improvement, we still will not be anywhere near the point of sort of no functional impairment. And if you go on the next slide, you can see that if one intervenes early, at least again hypothetically or theoretically, even with the same degree of improvement with a therapy, the baseline that the patient will reach will be much closer to our ultimate goal of having patients as functional as possible. So that's sort of the theoretical construct that certainly is being tested and requires continued testing, but it certainly is an attractive hypothesis. And I think that's my last slide. So I'd like to turn it over to Dr. McLaughlin.
Thanks very much, Dr. Chanik. It's a pleasure to introduce Dr. Valerie McLaughlin, who's a professor of medicine at the University of Michigan and director of the Pulmonary Hypertension Center at the University of Michigan Medical Center in Ann Arbor.
Great. Thanks so much, Greg, and it's a pleasure to be on the call today. So what I'd like to spend a few minutes doing is talking about what we might achieve in terms of ultimate outcomes if we were to diagnose patients at less advanced stages of the disease. And in order to do this, I would like to use a study that was recently published from the French group. And what they did is they looked at the difference in outcomes of patients with pulmonary arterial hypertension related to scleroderma based on the traditional diagnosis versus what they found when they got to patients earlier and they were screened more aggressively. So, and I'm focusing on the connective tissue disease population because we have some data here, but I think it likely applies to other groups too. We know that patients with connective tissue disease tend to be more advanced. And this slide shows some data from the REVEAL Registry showing that patients with connective tissue disease on the right here tend to have more advanced symptoms than other patients in the registry. And this next slide demonstrates the functional class distribution if we can get to patients sooner. And in this case, sooner means by screening patients at high risk, but sooner might also mean reducing the delay in diagnosis of symptomatic patients, really the topic of our call today. On the left, you see scleroderma patients that were found in pulmonary hypertension centers as part of a large French registry that was run in pulmonary hypertension centers. 75% were functional class 3 or 4 at the time they were diagnosed. On the right, you see patients with scleroderma who were diagnosed with pulmonary hypertension when they underwent an aggressive screening program in their scleroderma centers. And you can see there that almost half of the patients are less advanced in terms of functional class. They're functional class 2 at the time they're diagnosed with pulmonary hypertension. So we are going to compare the outcomes of those two populations, the scleroderma patients that present to pulmonary hypertension centers and get diagnosed with pulmonary hypertension because they have symptoms of dyspnea on the left, and on the right, patients that get screened for pulmonary hypertension in their scleroderma centers and get diagnosed that way. So the next slide shows those two registries and how they came up with the patients. The French registry on the left of pulmonary hypertension had a total of 74 scleroderma patients. Many of them were prevalent. And if we just looked at the ones that were newly diagnosed, they come up with 16 patients found from the French PAH registry. And then on the right, in the screening program, it just so happens that 16 patients were identified with initially cardiac catheterization and then confirmed with initially with echocardiogram and then confirmed with right heart catheterization. So we're going to compare those two cohorts, the routinely detected cohort and the aggressively detected cohort. here you see the characteristics of these two populations, and I want to make a couple of important comments. They're very similar in terms of age and in terms of gender and in terms of their scleroderma characteristics. But as I said, in terms of their functional class, the routine practice were more advanced than the detected practice. But I also want to make the point that look at how symptomatic some of these patients are. 7 of them, or 44%, were functional class 2. Half of them were functional class 3 at the time they were found to have pulmonary arterial hypertension. So perhaps we are not even screening these high-risk populations early enough. And you can see there's a difference in their exercise tolerance as measured by the 6-minute hall walk. The next slide shows their hemodynamics, and there are 2 take-home messages here. One, patients that are diagnosed earlier have less advanced pulmonary vascular disease as measured by cardiac catheterization. Their mean pulmonary artery pressure was 34 versus 49, and their cardiac output was in the normal range, index of 3.4, compared to a little bit depressed in the routine practice. So if we can get to these patients early, they have less pulmonary vascular disease. There's been less damage to their pulmonary vasculature. But the other important thing to mention really reinforces what Rich was talking about, that even though they have early disease symptomatically, they really have quite advanced pulmonary vascular disease. Their pulmonary vascular resistance is 600 dynes, and they've certainly lost a good portion of their pulmonary vasculature to the remodeling, to the disease of pulmonary hypertension by the time they get a pulmonary vascular resistance that high. The next slide demonstrates what therapies they were on, and an important point here is that even though these patients were detected on routine screening, they were symptomatic, they did have disease, and they were treated with pulmonary arterial hypertension-specific therapies. But here's the real important slide, and I apologize if the numbers don't come out well, but these are the survival curves of these 2 groups. Now, it's not perfect. There's lead time bias, lag time bias, and that sort of thing. But look at how different those survival curves are over 5 years in patients who are detected earlier and treated versus those patients who are found on routine practice, often having walked around with symptoms for years and years and years before someone diagnoses them. The whole point here is that it's very likely that if we can get those less advanced patients, if we can reduce that time from symptoms to diagnosis and start effective therapies in patients before there's been too much damage done to the pulmonary vasculature, it's very likely that the long-term outcomes, the long-term survival, will improve. So just to summarize a few take-home message, this is in a screening program, and screening programs may help find patients in less advanced stages of the disease, but it may also translate to the initiative that we're trying to put forth here, that if we can reduce time from onset of symptoms to diagnosis, that we will also get patients with less advanced disease, and that likely those outcomes will be better. So thank you.
Val, thank you very much for such a clear presentation of the data from a screening program in patients at high risk for disease. I thought that I might take this opportunity just to share very briefly some points from a recent white paper published, and then we could take questions and discussion. This is a paper written by top pulmonary hypertension medical professionals from around the world in which they reviewed important advancements made over the last 20 years and examined continued barriers to optimal patient care. And among their findings to reinforce were the findings that the mean time from symptom onset to diagnosis was almost 3 years for patients with pulmonary arterial hypertension. They also noted that most patients see 3 different physicians over that time frame before being diagnosed with pulmonary arterial hypertension. And because of these delays in diagnosis, more than 70% of patients have advanced disease at the time that the diagnosis is made. This really led this team of pulmonary hypertension experts to make a call to action to say that we need to diagnose pulmonary hypertension rapidly and accurately, and we need to build awareness of the disease among both the general public and medical professionals. And we need to have pulmonary hypertension and its symptomatology be highlighted for general physicians and other physicians to whom the patients may present first. And finally, we want to recognize that pulmonary hypertension specialists are crucial for the care of patients with this relatively uncommon disorder. They have the expertise in pulmonary hypertension and advanced treatments, as well as access to clinical trials and registries, which will continue to advance our knowledge in the field. And if they can collaborate with primary care physicians and PH specialists, patients will ultimately, we think, receive better care. So I think what we've tried to highlight in today's webinar, and I again thank the faculty for an excellent job, are the points that delays in diagnosis are common and unfortunately prolonged. We've also emphasized that early disease, early detection doesn't necessarily equal mild disease. The disease is often quite advanced at the time of early disease recognition. We've also come to recognize that in terms of who's at risk, it doesn't seem to break down among lines of race or gender or age. But younger patients, for sure, we need to be thoughtful of this diagnosis, especially when they carry a diagnosis of a respiratory disorder like asthma, and especially if they're not responding to therapy. And finally, we heard that even when we screen patients or when we screen patients and detect disease earlier with our effective therapies, there is at least some evidence that the interventions result in improved survival for our patients. And I think this is the reason that we are also interested in making sure that patients are diagnosed with this serious illness earlier. So with that, I'll conclude and open up for discussion, questions, comments.
Thank you, Dr. Elliott, and thanks to all our speakers for a really great presentation. I just wanted to remind everybody again to please make your questions not case-specific, just general, about the presentation. We do have a couple people with their hands raised. So Sylvia, if you want to unmute your phone by pressing *7, you can go ahead and ask your question.
Okay, can you guys hear me?
Yes.
Yes.
Okay. As being a person with pulmonary hypertension, or have been in the throes of whether or not I do or don't, I'm finding out, at least in my area, there is a huge difference in whether or not you might have pulmonary hypertension versus those that are severe with hemodynamics. When somebody has the lower, just borderline hemodynamics, there doesn't seem to be as much interest in maintaining the health or even trying to find out what's going on as there is for somebody that is severe in both hemodynamics and in their stage.
Could you frame that into a question? I think it was a comment, and we can accept it as that as a comment. Or
question
have a question.
Okay, I'm sorry. What can patients or caregivers do if they're in this situation in regards to communicating with their physician, the importance of early diagnosis and early treatment?
I think what I'd like to do is maybe ask Dr. McLaughlin if she would take that one, and then ask the other faculty if they have comments to add.
Sure. I think, Sylvia, what you're identifying is one of the gaps that we're trying to close here, just because if you look at data from the NIH registry or any of the recent trials, patients have more advanced hemodynamics by the time they go into the trials doesn't mean that patients with less advanced hemodynamics don't have the disease. So I think it's a process of education that we all need to work together on to make sure that patients are appropriately treated. Having said that, there may be other extenuating circumstances, other things that also need to be treated in a patient with more modest hemodynamic impairment but more advanced symptoms. So there may be multiple things to target.
Right. So it should be more of a group effort from all of the physicians involved in the patient's care.
Exactly.
Help the whole.
Yeah, you know, the presenters on the phone today, we're all in pulmonary hypertension centers, and you know, we don't often see patients until they're more advanced. We're not always on the front line, so we need to figure out a way to work with some of those physicians, like primary care doctors, on the front lines to try and identify these patients with less advanced disease. That's one of the purposes of this initiative.
Okay.
Great. All right. Michael Ryan also has his hand raised, so if you just want to go and unmute your phone by pressing *7, you can do that and ask your question.
Hello. So I am a community pulmonologist, and with a fair bit of PhD. I used to be in academics and did PhD there, and you know, you talk. So the reason I say that is because we've started to do working with the university. We got a recombinant bike for our cath lab, and are starting to do exercise protocols for folks with kind of high risk, like the scleroderma folks, or with kind of these upper limits of the mean PA pressure being 21 and 24, or and do you guys have any thoughts as to where you see that going? Are we kind of following a fad, or do you think that's actually something that is going to make a difference?
I might ask Dr. Chanik to take that as a start, and then if other faculty have comments, please add them.
You know, I think it's not a fad. I think it's the next sort of big wave, and I think there's a lot we can learn about what happens during exercise, and certainly conceptually it makes sense. Patients get shorter breath when they exercise, not at rest for the most part. And so what happens to the pulmonary vascular system with exercise is very critical, and we absolutely see patients who have inappropriate rises with pulmonary hypertension during exercise, and that's not normal. The question is, of course, what does that mean clinically? And there our knowledge is evolving. I just speak from personal experience because we have a very sophisticated exercise lab here where we don't just do hemodynamics but actually look at CPET with hemodynamics, what we call level 3 exercise study. And so not only can we identify patients who have pulmonary hypertension with exercise, but we also can identify whether that pulmonary vasculature is limiting their exercise capacity by doing maximal exercise with the SWAN in. And in fact, we do find a group of patients where that absolutely is the case, where they have a pulmonary vascular limit to exertion correlating with the pulmonary hypertension that's occurring. Now, we still can't answer the next question, which is longitudinally, is that something that will progress? Is that something that should be routinely treated? And that's where we need to go. And until we get to that point, it's certainly hard to say everyone should be treated when they have exercise-induced pulmonary hypertension. In fact, that's why it's no longer in the definition of pulmonary hypertension. It's not because it doesn't exist, but it's because we're still learning about what it means.
Okay, but I guess if you go with the construct that, well, I don't know, excluding those patients in the early study, because those are...
Yeah, that's not the same group.
Yeah, that's a sick patient population. If we say that we have a high pretest probability for some form of pulmonary venous or pulmonary arterial hypertension, often these folks have had a CPET before we cath them. Mm-hmm. Is it reasonable? Is there going to be any ongoing trials that we could get patients into for that?
There are some that are being either contemplated or occurring. sort of investigator-initiated studies, some including a few different centers, and certainly if you email me, I can let you know sort of specifics, where there are interventional studies looking at a specific therapy in patients who have exercise-induced PH, and looking at sort of before and after parameters. Yes.
Okay.
Happy to provide that offline.
Okay, thank you.
All right, so we have 2 more people with their hands raised. We're going to have them ask their questions and then wrap up. So Joan Stevenson, if you want to press *7, you can ask your question. And then Teresa, you can also ask your question after Joan.
Okay, my question is, and I did come in late for this. How do you PH specialists reach out to PCPs in order to educate them to recognize the disease earlier?
Actually, thank you very much for a very nice question. I'll ask my colleague, Dr. Lynn Brown, to speak to that.
Yeah, I think it's probably the most important thing we can do is outreach to our colleagues, and we do that through speaking engagements with other physicians to try to get the idea of pH and the symptoms and what patients look like, so that everybody will recognize them. Especially, we talk to physicians who have high-risk patients in their practices to try to get them to recognize patients earlier. But it is a huge part of why we do the talk today and why we are continuing to try to come up with better ways to communicate, because as Dr. McLaughlin said, that is the key to everything, is educating our peers.
Thank you very much.
All right, Teresa, if you want to go ahead and press *7, you can do that and ask your question.
Yes, hello. This is Teresa, and I'm a PAH patient. My question is that, with a comment followed by a question. It seems that there are some general cardiologists and pulmonologists who are prescribing PAH-specific medications to patients who they've identified with PH, but maybe not PAH, and or they don't refer these people on to a PH center. Could you comment about that a little, please?
I thank you. I think that's an important question as well. I'm going to ask my colleague, Dr. Badish, to take first crack at that question, if you would, Dave, please.
Certainly. I think what you're talking about is what we call off-label usage, which is using the drugs beyond their currently approved indications. And that sort of usage is often in the absence of good evidence supporting benefit or efficacy. And personally, I'm very cautious about using our drugs in these off-label situations in the absence of evidence supporting such use. I think not only may they not be of benefit in that situation, but there is some potential for harm. And I think you're right, there needs to be caution in the community regarding prescribing these drugs. They are associated with some potential side effects. They're very expensive, and their benefit, beyond what's been studied, is uncertain. So I would recommend considerable caution in using these agents in patients outside of the WHO Group 1 population in which they've been studied in a general manner. I guess, I might add that it's another good argument for prompt referral of patients to a specialized center. I think the patients ought to be referred to a center prior to the initiation of therapy, and we're certainly trying to encourage that through the sorts of outreach programs that Lynn Brown just mentioned, and through programs like this.
Dave, thanks very much. I think I'd only add that sometimes diagnosing Group 1 pulmonary arterial hypertension can be challenging, and I think that is the reason to have people with experience and expertise participate whenever that's feasible. I understand sometimes that's not feasible for a variety of reasons, but certainly I think it's to be encouraged for the reason of having a correct diagnosis and then providing correct therapy because of the risk-benefit ratio. Perhaps I can take this opportunity to thank everyone for participating in this webinar. I think we've made a great start to not only putting the message out about the delays in diagnosis and the importance of recognizing patients with symptomatic disease earlier, but we've also seen some important new data, and I hope everyone enjoyed this as much as I did.
Great. I just want to add an additional thank you from PHA for our speakers and this wonderful presentation, as well as for all of you for being involved. Thank you very much, and thank you, Dr. Elliott, for a great facilitation of this presentation, and to all our speakers for just a really great conversation today.
Okay. Thank you.
Thank you.
Thanks, Megan.
Thank you. Bye-bye.
Bye, everybody.